So again, a very warm welcome to the panel. And I'm going to ask each of you to introduce yourselves in turn, a minute and a half of who you are, what your background is, and then I'll start putting some questions to you. I'd like to open with Carrie. Carrie, would you like to introduce yourself? Carrie, you're on mute.
Yes, good afternoon, everybody. I'm the non-specialist in this group. I happen to only have the diabetes 2, and I was chosen to this panel because there has to be somebody who is bringing the voice of the people who are having this disease. And I have an interesting experience by working in different countries and starting my diabetes project with different doctors with different types of diabetes systems in Belgium, Finland, and Spain. So I can share that experience. At this moment, I'm working in EUIPO in Alicante. I'm the educational outreach expert. Thank you.
Thank you, Carrie. Over to you, Bastian.
Yes, hello. Pleasure to meet everyone. Hello to EASD. Hello to the EASD audience. My name is Bastian Haug. I also live with diabetes. I live with type 1 diabetes for almost 25 years now. I am a board member at the German Diabetes Association, Diabetes.de, and I have been on the board of IDF Europe hosting today's symposium for almost 4 years now. Other than that, I started founding DDoC, which is a platform for diabetes advocates. So for people living with diabetes who care about patients' rights, who, as we say, pay it forward. Some of them are attending EASD right now as we speak and will be speaking at Doc Day on Thursday. I invite everyone to join that as well. For today, I will be representing the voice of people living with type 1, but also in general, I've been working a lot in the type 2 space through IDF Europe, through Diabetes.de, and I look forward to an amazing debate with amazing speakers from the healthcare systems approach. Thank you.
Thank you, Bastian. And it's quite a day for Bastian because usually he ends up hosting these things. And today he's in the hot seat. So very warm welcome to you, Bastian. Jose.
Hello. Good afternoon to everybody, and thank you very much for the invitation. My name is Manuel Buavida. I'm an endocrinologist. After a long time, I worked in diabetes education. I was president of the Diabetes Education Study Group of the EASD. And afterwards, I was president of the Portuguese Society of the Diabetology. I'm a member of the European Public Health Alliance. I'm president of the Portuguese Diabetes Association, and I'm currently in the board of IDF Europe since 3 years. So I'm here to collaborate in all these big problems for the current times and for the permanently challenge that they are for our daily work. Thank you.
Thank you, Jose. Manuel, over to you.
Thank you, Niti. Good afternoon. My name is Tanel Ross. Very happy to be present and very happy for the invitation. I'm from Estonia and I have quite a long background from public finances. And I was also 5 years chief executive of Estonian Health Insurance Fund, which is a social health insurance fund in Estonia. I'm currently working as an advisor to Supreme Council of Health of the Kingdom of Bahrain on a term appointment, and also have a part-time appointment at Tallinn University of Technologies. And Niti, as you alluded to, I hope I can give some perspective into this panel from a systemic background, perhaps a little bit from Estonian experience, what has been done, but I think even more from my experience in Estonia, what should be done, what is not necessarily be done yet in Estonia. Thank you.
Thank you, Tanel. And we're very lucky to have you on the panel. Thank you for accepting our invitation here. Magda, over to you.
Thank you so much. And I'm really delighted to be here. Thank you very much for the invitation. It's my first time, hopefully not the last one. I'm coming from the European Federation of Pharmaceutical Industries and Associations, FPA, representing about 2,000 R&D companies of all sizes across Europe. In my organizations, I'm leading science and regulatory team with the mission to accelerate delivery or to enable acceleration of delivery of innovation that matters to patients and to society. And we have in our portfolio large-scale collaborations and public-private partnerships, as well as digital and data strategies. The Innovative Medicines Initiative and the Future Innovative Health Initiative, it's part of that toolkit. So I would be very happy to share some of these experiences with you today. Thank you.
Thank you, Magda. And we're delighted to have you today. And it isn't the last time. Now that we found you, we're not going to let go. Nick, over to you.
Thank you, Nidhi. Yes, my name is Nick Klaasenga. I have a medical background, but the past 15 years, I've been leading the work on healthcare quality and outcomes at the OECD, the Organization for Economic Cooperation and Development in Paris. And I'm combining that with the professorship at the University of Amsterdam. I'm mainly involved in trying to collect data on the performance of healthcare systems and trying to figure out what this performance adds to the value of the systems, not just monetarily, but mainly on outcomes. So I work with registries, including diabetes registries. With researchers, I try to infer from administrative data how care is delivered, including avoidable hospital admissions for diabetes, or during the COVID period, especially the drop in GP visits and the drop in laboratory tests related to diabetes. But the past years, more and more on patient-reported outcome measures, since the ministers of the OECD countries asked in 2017 to put emphasis on patient-reported information and collecting that. So also being happy to bring that in the discussion. Of course, my discussions are always broadly, they have to do with data infrastructure in member states and how to govern that. And they have to do with overall trends for digitalization and how that would be of the benefit of the economy. But at the end of the day, of course, it is about capturing whether care for diabetes patients is actually adding value. And pleasure to be in this debate.
Thank you, Nick. And we're so lucky to have you here from a systems perspective, but also from your own work on PROMs. And I'm sure the audience would love to hear from you on that. Stan, last but not the least, you're a very engaging speaker. I've been with you on many platforms, so I'm delighted to welcome you today.
Thank you, Nidhi. And I'm not sure I'll be able to live up to that introduction, but thank you very much. And good afternoon, everybody. I'm Dr. Stan Shepard. Thank you, IDF and EASD, for the opportunity to take part in what is, I think, a very important webinar. My first degree was aeronautical engineering, and then I went to medical school at the age of 29 to become a doctor and became a GP, a family physician. So I've always had one foot in technology and one in clinical medicine. I put a computer into our medical practice in the very, very early days, and then went on to develop our own GP electronic record system. We did well in Belgium, Ireland, and South Africa. And we also became the global partner for Special Olympics, working with people with intellectual disability. From that experience, we came to believe that the citizen should be the primary data owner with their own lifelong personal care record, held and owned by the citizen. So I founded a company called Instant Access Medical. We took our GP system, knowing that we had a comprehensive platform to build on, and we developed a lifelong personal care record for people on their mobile phones. So very, very strong interest in patient-centered data.
Thank you, Stan. And as you can see on this panel, we have a variety of views, both from a system perspective, from a European perspective, from a pharma perspective, from a patient with diabetes, a healthcare professional, and a whole host of others. So I'm going to start this debate by asking you for questions. And if any of you want to answer, please unmute yourself. Really happy for you to take the question rather than anyone else. So we know, and there's a broad consensus, I think, emerging across the world. I also work in many, many countries across the world. There's a consensus that data sharing and data usage will improve patients' outcomes and quality of life. We know this is free resources for healthcare systems and healthcare professionals. This is something that people look to do. I don't know whether I'd be ever able to practice medicine now without my computer in the consulting room. Support policy initiatives that improve health system performance, things that you alluded to, Nick, and lower costs and maximize resources and revenue for healthcare systems, which is what you alluded to, Tanel, and the work that you've been doing, and pharmaceutical and medtech companies in the context of value-based healthcare system. And people talk about value in value-based healthcare systems. So we know there's broad consensus around this, but I'm going to dig a little deeper into this. So really, are there any differences in which data is handled? And what data are we referring to? Any issues around data ownership, for example, user-generated data? So this is your wearables, your Fitbits, your blood pressure monitors, your blood sugar meters, and the stuff that people are now sending back from their connected device into medical records. So it's a question out there. Is there any difference between that and the data that health systems or your EMR picks up? So anybody like to take that first bit of it, or would you want me to direct it at somebody? Anyone want to have a go at that? Bastian, do you want to start?
I'm happy to do so, Niti. Thank you. I think there is a difference, but at the same time, there shouldn't be, because there is data, Stan was referring to this, that is in the healthcare records, the more medical data, and there is data now coming through all different kinds of means, starting from wearables or social media or how you shop on Amazon. And we know it's being analyzed in some areas, not so much in healthcare yet, but it is more and more becoming so. That's the user-generated data. It's also the user-generated data that comes from my insulin pump, my CGM sensor, my blood glucose meter devices, which are all connected now. And it does make a lot of sense to combine these kind of data streams, no matter where they're from. There needs to be limits on how this data is being used. It needs to be sure that this data collection is easy for me as a person living with diabetes. I always say that we have to start from where the data is coming from. The burden of collecting or donating or giving this data for the bigger goal can't be higher than the benefit I personally or the community receives from it. But then also we should make sure that this data, and I'm sure Stan will have to say will have something to say about this. We need to make sure that this data is safe and that it's accessible to me, but also to others, because I'm a big believer into big data, into learning from the data of others. I come from peer support, where it's not necessarily about data, it's more about exchange. But I've seen firsthand how great it is if people can, have an exchange on how they live with diabetes. Why not have them enabled to have an exchange about how they use their data? But how do we do this safely? I don't know. Coming back to your question, I think there is big differences in medical data and user-generated data, but what I believe should be the same is it should be accessible, it should be owned by the person where it comes from, but it also needs to be accessible to the healthcare system and also to pharma and medtech companies who are best equipped right now maybe to work with that and lift these benefits that we ultimately will profit from.
And Jose, you had a really interesting take on this, particularly around the social determinants of health data, which we don't always talk about, we don't always factor into the car. And I think, Nick, you probably will have something to say on that as well from your OECD work. So Jose, over to you on this data that you think ought to be incorporated. You're on mute. Yeah, go ahead, please.
Yes, I think we have thousands of indicators and numbers that's all we call the data. But sometimes we forgot all the data related to people, to socioeconomic status, costs, healthcare systems, social characterization, employment. And I think this is very important to have a unique point of coming of data, because it will be impossible to learn all about someone. If we can look to the importance of social determinants of health, which include, of course, housing, education, transportation, income, and food insecurity, have quickly become the most critical influences in care outcomes. We doctors, we are most concerned about biochemic numbers, and we forgot most of the time social aspects and psychological aspects. And I think it's very important to come to these social determinants and to have the capacity to put them in the same register. Of course, this is a big effort to look to someone and to understand who is he, who he lives with whom, their income, all these kind of problems, they are normally forgotten by the companies, by the doctors, by the health system. And I think now that emerging technology tools we can arrive to a single patient identifier that could bring a more comprehensive view of a patient and offer insight into their ability to benefit from specific care plans. I think this is very important to look to this data, not to build a hobble and to have an algorithm that will say what we must to do, but to understand that it is not possible without understanding who is the person that is there, that we can make profit of all the data.
Carrie, did you raise your hand? Did you want to talk about this, or shall I move to Nick? Nick, I just quickly bring you in here. Carrie, did you want to say something first before I bring Nick in?
Maybe a few words in order to clarify this from the patient point of view. So I was diagnosed in Belgium, and I got my results, and they were not understandable for me because they used a different kind of system to measure the glucose than in other countries I've been used to. I moved to Finland, and I found a good doctor. And in Finland, we have a good system for patient data. It's called Omakanta, and you get all the laboratory results there, the doctor's information, everything there, and you have to have a strong identification before you can get in. I was very pleased with that system, and for example, my last visit with the doctor was online because of the COVID, and we could both look at my data, my latest laboratory results, and discuss about what should be done. Okay, I moved to Spain, and once again, I had to start from beginning. There is no system between the European countries to, for example, for digital prescriptions, which we have in Finland. I had to do new tests, new sessions with the new doctors, and in Spain, we don't have this kind of electronic, at least I have not found. So everything is on paper, and everything is once again a bit mixed. So from the patient point of view, it would be good if in Europe we could have, because people do travel. We have Schengen, we have free movement of people, we can work and study wherever we want. There should be a system that we can prescribe medications to the pharmacies in other countries, so especially in diabetes, so that we are not in a trouble when traveling. And this is, I find, something which I really wish. On the other hand, in Finland, we have had a serious breakdowns in the patient data systems. For example, mental health information of 32,000 people were stolen, and people were blackmailed about their mental health issues. And so if there is this data, it should be well guarded. And the last point, do I want pharmacy companies to use the data? Yes, if it's anonymous. I don't want to get any mails from pharmaceutical companies that because you have diabetes, try this, try that, because I don't want that they get my personal information. Thank you.
Thank you, Carrie. And Magda is going to answer some of this. So we've had, here are two patients that are telling you, two citizens that have their data that are telling you they like you to use it in this kind of way. And you've got a system that may or may not be able to even collecting that data. So, and Jose talked about the social determinants and an algorithm that could tell you more about the patients. There's lots of that about. It's the new oil. In my view, healthcare data is the new oil. And we know that in places like Israel and in Korea, there actually are going to be a central data repository set that the government is going to be able to use and monetize. So we'll talk about that in a minute. But Magda and Nick, did you want to come in on this?
Yeah, sure. You're already putting a lot of topics on the table. Let me reflect from the perspective of the patients, which was the contribution from Jose and from Kari, and let me reflect from the perspective of the population. From the patients, yes, I totally recognize your stories, that the ways how there is an interaction based on data between the patient and the healthcare provider differs from country to country. And I think an important element to take into account there before you end up in a political discussion is why you're doing that. You do that because you hope that people will share the information that is of importance and that it will contribute to their own care. So, Niti, when you just drop the word value-based healthcare, please realize that value is not made by healthcare systems. People create their own value, and you can use data to support people in creating that value. And with chronic diseases like diabetes, that is an important element. Now, what do systems have in place? In Finland, you have your Kara system. It's electronic, it's well linked. You have electronic prescribing. In Belgium, you don't have that. It also differs on the region where you are, and the same in Spain. So there we get the story of, do the data systems support this? So then, in principle, yes, it should be owned, and people should be using their own data because they need it for improving. And when you look at the literature on prompts, especially in the cancer fields, that's also where you see that there is an added value. If it's only collected for research, that's not enough. It should be part and parcel of the consultation. And luckily, we saw during COVID that in more and more situations, this data is used for the dialogue. But so that's one principle. It should be used in the consulting room. But then we see quite a lot of differences between countries in the interoperability between systems of a general practitioner, a hospital, a pharmacy, and like having universal access to the prescribing data or the laboratory data is not everywhere the case. That's what I call the discussion on the patient, and happy to have that debate, but it means that what the OECD does is supporting countries to push them to really set up a data infrastructure that facilitates that, with the ultimate aim of using the data by patients themselves. The other perspective is the population perspective, and that's more the aggregate data. That's not necessarily patient-based. It's basically collecting all the statistics that help you to make sense of how a system is doing. And there, you can also add what was just done, the idea of social economic determinants. But the essence is, because I work with a lot of these data, I can only make sense of amputation data, avoidable hospital admissions, drops in HbA1c tests during COVID in a country, when those statistics can be disaggregated by socioeconomic groups. And usually you can may see a difference between men and women, but the moment you try to refine that, for example, the people who stayed away from their GP with their diabetes 2 in the past 18 months, are that mainly people who have already, were from a different socioeconomic group, having difficulties, other things to struggle with, other fear, and then to really seeing on these I'll give you an example. I saw this weekend the laboratory data from Canada, from Ontario. You see a 40% drop in visit of GPs during the first phase of the pandemic. But I would really like to know who were these people who stayed away. Can't do that if I can't disaggregate to the level of socioeconomic groups. Just across, there is a whole debate about optimizing the use for individual patients, which has to do with interoperability, GDPR, privacy, and ownership of the data. But there is also a big debate about secondary data use. And I can compliment Kari with Finland that your country passed a law 2 years ago on the secondary use of data, where there seem to be a population trust of collecting this data and using it not just for the individual to be better, but seeing the win-win situation in sharing. I'll stop there, but those are important elements in the discussions that I discussing with OECD member states on data.
Niti, I think you're on mute.
I was trying very hard not to cause an issue, and there we are. So lots of lovely threads, Nick, coming out from your conversation and from the others. But I really wanted to pick up a point that Carrie and Bastian both raised around pharma, medtech, user-generated data, and how pharmaceutical companies and innovative companies, and with pharma, I wouldn't just want it to be pharma. We've got new digital therapeutics companies in the world that are doing care management and management of diabetes in a very different way, which I view just like a device would do that. So any thoughts on that, Magda?
Thank you. And I think almost everything had been said in reality, and you've all mapped all the topics in a brilliant way. I maybe take it back about why we want these data and why we want to have access to those data, and say we collectively as healthcare systems and research communities. Well, patients and doctors because they want to better manage the disease, healthcare systems because they want to better manage the resources and the outcomes, and researchers because we need to change the paradigms of research. We cannot continue doing like years ago with some sequential, phase 1, phase 2, phase 3 and post-marketing. It just simply doesn't work. We need feedback loops, learning and confirming, and more adaptive systems. So all of us have very legitimate reasons to have access to insights, whether data or insights or returns from data. And it's not always access to data or having access to patient level data. Sometimes it's just access to the insights. And the systems in Europe should actually enable that. All three of those aspects should be enabled by the data infrastructure and by the way that the governance around the data and access to the data is organized. Whether it is a centralized system, which might be possible at the level of a region, or a federated networks, as we are trying them in the Innovative Medicines Initiative through the EDEN system. I mean, that's really to be seen, and it depends on the purpose that one wants to achieve. But what is really important is what colleagues said about, patients do not want to be bothered. They want to have a return on sharing their information, and that is organized through a proper governance about data and access to the data and portability of the data and all of that. So we are at a really unique momentum in Europe of creation of the European health data space. There is an opportunity to do it properly from day one and make sure that we take learnings from all the initiatives that are on the table now and scale them up. So I can just provide this example of EDEN, the European Health Data Space Network, and H2O, Health Outcomes Observatories, which are creating tools with this patient responsibility and empowerment, data security, clear standardization so that we have a good quality, and also these third parties, neutral brokers that create access to the data, or rather generate insights for researchers who ask research questions. So just in summary, I think that the question of infrastructure and proper governance needs to be established now, and we have a unique momentum in order to do that all together.
Thank you, Magda, and great pulling together of the threads. I see you've done this before, but I'm going to come to Tanel. Tanel has run a very efficient healthcare system, and he's done a lot of work in this respect. So in Estonia, you went digital long before the rest of Europe caught up. So just some insight from you, Tanel, on this whole digitization process. Who owns the data, the governance of it, and how we can use it? Just some insight from you on that.
Thank you, Niti. Really, just a few remarks, because really a lot of it has been said already. But I would like just to probably just to start by emphasizing the importance of putting the data and the exponentially grown computational assets in use for patient empowerment. And you said, or everyone has said very correctly, that this is, I mean, it improves health outcomes for on a patient level for public health. I think it was, at least what is my view is that we should also understand that the success of this leap is also very important so as to universal health coverage system as we know it in most of the EU and in OECD would be relevant for the population. I mean, if one thinks how much data has been used in all other areas of life, and indeed, I think the generations, I mean, my kids for sure, expect that the same approach in healthcare. So I think really that this the success of this patient empowerment in a sustained manner, in a manner that improves the population health in general, is indeed an extremely important also so as to maintain the universal health coverage and the goals as such. Now, on the data, and of course the basis of this is data availability. Data availability in turn depends on interoperability. What data is available centrally, as it is in Estonia, as part of the national electronic medical records, where every provider has to contribute. But it is not only about the central repository, it's also how you can use the health records of hospitals, health records of the providers, and indeed, as Bastian already mentioned, how to use the data stream that comes from in the future from all personal devices. So this is really, I think, the key how to make all these links interoperable. As far as I understand, in Estonia, currently we have this central information system in place for over 20 years already. But there is still, I mean, work to do on how to ensure that the data is usable also from other sources that are relevant. Now, the third point what I would like to emphasize, and this I think was also already pointed out by Jose and by Nick and by others, is that eventually the success of the digitalization and the success of how data will be used depends on the relevance for all stakeholders, relevance for a patient, relevance for a physician, and indeed the relevance for a provider organization and the relevance for a payer. So it is not only, I mean, what is my experience is that very often the data use is looked at on a pretty narrow perspective. But if I from a health system point of view, I would like the data be used in such a way that it is relevant for a patient, right? So the patient has an access to the data that he or she owns, and this data is well first and foremost it is presented to him in a comprehensible, easily comprehensible way, that he can easily use this data for his own everyday life or care management as the case might be, and this data would improve his or her health literacy. And from the physician side, at least, this is our experience. Obviously, you can put in place administrative regulations that the data should be provided, but we all know that providers and physicians will go along with these regulations if they see an more or less immediate benefit. Well, for instance, if you can really have a good central system, and if it is therefore relevant for GP, because he or she has an access to electronic medical records and possibly also to health records in hospital, for instance, this incentivizes the GP also to pressure the let's say regulatory authority or government to ensure that the data is available, that is interoperable, etc., and so on and so forth. So data availability, relevance of how the data is used. And then the third point that I would like indeed to point out is that again, as we all know from a systems perspective, it is extremely important that we have we have a framework and incentive structure in place that the data availability will improve and contribute to the patient empowerment in all relevant, regarding all relevant health conditions, most notably chronic conditions. And that leads us to the question how to incentivize this value-based or value-creating use of the data, both by the providers and also, as was mentioned, by the patients. So these are probably remarks. In Estonia, we have some of these elements are in place, some are not yet not in place, but I think it is understood that the relevance of the data use is extremely important, and incentive mechanisms to ensure that you get out the value of innovation and of development is also well understood. Thank you.
Thank you, Tano, and really interesting insights there. But Stan, I'm going to come to you in a minute. And this is some of the thread that's been picked up by all the others around access to data, access to records, and access to what's going on in your own lives. So for me, as a doctor practicing in inner city Birmingham, not many moons ago, I'm not that much of a doctor anymore, but doing that many years ago in a practice where 33 different languages were spoken, and I gave access to my email address to my patients with diabetes, and everybody thought I was crazy. This was about 18 years ago, and everybody thought she's a mad woman, she's going to make a rod to break her own back. And actually what I found was patients used it very sensibly. They didn't send me an email out of hours to ask, what to do with their blood sugar, but they used it very sensibly. So just on that debate about access to records and making sure that the access to the record is relevant as well as being visible and transparent. Because to a patient, if you've written a load of gobbledygook in medical Latinese, it's not going to make much sense to them, right? So how we put our data together in an EMR is also important. So over to you, Stan. Your insights on that would be great, because you've done that for a living for many years.
Thank you, Nidhi. Thank you. It's fascinating points everybody's making. I don't know you're going to get that much controversy. There seems to be tremendous unity in what people are saying. My first point, I think, Nidhi, in response to that, when we talk about what kind of data, I think there are two sorts of data, and I think somebody said it already. As we all know, you can derive research and administrative data from clinical data, but you can't do it the other way around. So clinical data has to be at the heart of it. If you ask people to step outside their normal daily activity and collect data for you, you get a poor response. If the data you collect falls out of the day-to-day use clinically, you get much better data. So my first point would be we have, and the use of the data should be the number one priority is that will benefit people with diabetes directly. And we've heard about patient-generated data, remote patient monitoring, wearables, etc., is going to be a game changer in diabetes and every other long-term condition, not only for the data it provides, but to feed back to people their own parameters. As your blood sugar goes up and down, or as your blood pressure goes up and down, you feel nothing. So when we see a patient in the clinic and we say, we measure their diabetes, their HbA1c, and we say it's raised, what have you been doing for the last 3 months? The patient can't remember. There's no association between your parameters going up and down and what's causing that. On the other hand, if you say to people, if you can give them continuous glucose monitoring, and that goes into their personal care record, the record can be proactive and can say to the individual, your glucose has been very good for the last 4 hours. Whatever you've been doing, keep doing it. Or your glucose has been rising. What is it that you're doing? So that on a day-to-day basis, you can enable the patient to start to correlate their personal behavior with these parameters of things going up and down that they don't feel. And only by that feedback loop can you do that. You can put in directory of services. We heard about patient rights. There's a ton of information that you shouldn't have to go all over the web to find. It should be on your mobile phone, on your record. And that record, as you touched on, Nidhi, should be proactive. Giving patients access to doctors' data, of course there's value in that. There's no denying that. But it's a very limited value. we as doctors might be able to see somebody else's notes or data and derive conclusions from it. That's much harder for most patients. We should take the data, extract it from the provider systems, put it into the patient's own record, and then it can be proactive and we can present the data in a way that's meaningful to the patient. The other use, of course, is research. You've got much better experts than me touching on that, but I would say your research data will be far, far better if it's derived from clinical data than, for its own sake. I couldn't agree more with Jose's point about the contextualizing the data. And the easiest way to capture the context of somebody's life is to let that citizen enter that themselves in their individual personal care record. And the heart of all care historically has always been continuity of care. It's the best way to diagnose and treat people. But what that's really represented was continuity of data. And in paper systems, the data is locked into one location. So we don't have continuity of data. Estonia has, but most of the world doesn't. So historically, people saw their doctor face-to-face in the doctor's surgery or hospital or clinic, primarily because that's where the doctors kept their data. Now, digitization is going to remove the dependency of data on location and organization. The patient pops up everywhere at multiple places and multiple organizations. So it has never made sense to lock patients' data separately in all the different places and organizations the patient goes to. Digitization and personal care records will enable the patient's data to become portable and move with the patient, not stay with the doctor. Of course, the doctor has their own copy, but the patient takes it with them. So we need to flip from patients needing to see doctors' data to doctors needing to see patients' data, and access to your data isn't enough. It's got to be proactive. And it also is a great way to accelerate interoperability. And there are plenty of precedents for citizens carrying their own record. We don't have a separate credit card account for every shop we visit, where the shop believes that the data belongs to the shop and where the shop decides whether it might or might not allow us to hold that data ourselves. And that's what happens in healthcare. Of course, we wouldn't tolerate that. The transactional data belongs to me as much as it does to the shop, and I have a single account of my credit card account that moves with me wherever I go and wherever I shop. People holding their own records has happened for years in antenatal care. Mothers and clinicians both have copies of their record, and mothers are way, way better. Mothers-to-be are much better at preserving that data than hospital departments. So I think that the access to the data needs to be primarily for the benefit of the person with diabetes or any other chronic disease for that matter. It's overdue for that data to be portable with the patient. And I think, Carrie, how much it would have helped you to have your own multilingual personal care record going around those 4 or more countries that you went to. So I think it's overdue for the patient data to be portable and move with the patient and not just stay with the doctor.
Thank you, Stan. And just my little 2 pennies bit on that is I work a lot in emerging countries. I work in economies that you wouldn't recognize as mature, and where the aggregation of data is happening at different sources as well. It's happening at the lab, it's happening at the pharmacy, it's happening with your private doctors, happening everywhere else, and they're handing the data to the patient. I don't know whether you saw the aggregation of 1mg with ThyroCare in India, where there's over about 25 million records aggregated upwards through labs and pharmacies, and a whole different 3 new drugs discovered as a result. So again, a very different play is happening in different countries in Europe. We just haven't kept up with it. So I'm going to bring that debate back to the patients or the people with diabetes, and Bastian and Carrie. I think Carrie put his thumb up when he heard you speak, Stan. So I think you should connect afterwards and have a chat about this whole personal care record. I believed in it for 25 years, and I'm glad we've got that debate happening today. But from a patient, thank you. And from a patient perspective, really, I just wanted your views back on some of the things that have been said by Jose, Tanel, Stan, Nick, and Magda. And the one question I'd like to throw back at you, I don't think you'd disagree that you need your personal care record, right, chaps? Carrie and Bastian?
Fully agree.
Yeah. Coming back, the new oil in healthcare, which is data, and the stuff that Magda's touched on, the innovation and research, I think patients are pretty altruistic about their data is what I found, but it's got to matter to them. It's really got to make a difference to them as well as the whole system upward. So Bastian and Carrie, what matters to you on healthcare data? And here's your chance to have your soapbox on this. You've got a health systems expert here. You've got a European expert here. You've got the pharma industry here represented everywhere. And you've got somebody representing your patient care record and a healthcare professional. Here's your soapbox. Here's your 5 minutes of glory. Tell me what you want.
Well, if you don't mind, Carrie, let me start and also refer to something that you said. First of all, Stan, couldn't agree more with how you link continuity of care to continuity of data and everything that goes with it. Some great points you raised there. And Carrie, I completely agree, but I also disagree with you on one thing, and that maybe links it together. And I would love to hear some other perspectives on that, really. You said, I'm happy to share my data as long as it's anonymous. And I get that. And you linked it to, you know, I don't want to get pharma or medtech companies emailing me about whatever. On the other hand, I've also been involved with a couple of research projects, and I've always seen how limiting that can be. If we only agree to sharing data anonymously, as much as I understand, and there are some questions in the chat about, you know, how about if our data is then being sold for profit, etc. I know there's tons of things, and I'm not saying I'm not taking these concerns seriously, and I do believe sharing data has to be safe, and it has to be, you know, you have to be in control, you have to be able to give consent and withdraw consent. However, if data that's being shared is only being shared anonymously, then the benefits we as a person living with diabetes, we as a patient community in general can derive from that, the benefits that researchers can get out of that, that health systems can get out of it, will remain limited. And I've seen that in some of the research projects I've been involved by myself or through a patient advisory committee. So this is going to be a tricky one moving forward. And Magda, I think you referred to the H2O and the European health data space. We are, of course, as IDF Europe involved in that. And you said we have to get it right. And we're kind of, I feel, stepping on each other's toes here, or kind of preventing us from doing it right now. Because on the one hand, we want to be so careful about not making mistakes and not sharing it too broadly. On the other hand, if we do that too restrictively, we're not going to get what the opportunities, we're not going to reap the opportunities that are out there. Now, you know, if you look at big data players like Amazon and Google, we see how powerful it is if you can really look at if you can look at user-generated data. We see what Amazon, Google, and others can do with it. And yes, it is scary, and not all of this is good. So there needs to be rules in place. There needs to be red tape. On the other hand, isn't it quite amazing what they can do and how they can tailor and personalize ads going your way? Now, I wouldn't want that in my healthcare system, right? I wouldn't want tailored ads going my way, but I would want research, and I even want pharma companies to be able to personalize care, or my GGP for sure, personalize care and be very clear about what's going to help me best. And that's not going to work with anonymized data. Big data, if it's completely anonymous, is just a heap of data. So that is going to be, from my perspective, really interesting. And I'm not the expert here. There's some others on the call that are, but I'm really looking forward to see how we can resolve that. How can we share data in a safe way so that it gives us the benefits, which means that it cannot be completely anonymous, although that's something that the patient community has been calling for.
And actually, there is a question here in the chat from Gary Tan, and he says, in the UK, there's been a lot of publicity about people opting out of sharing their data because of concerns about the government selling data to data mining companies like Google, and we just alluded to that in a minute. How is this overcome in other countries? Is this just an irrational point of view from the UK? And then inverted commas says, no comments about Brexit, please. So please do not comment about Brexit while we do this. I love that. So me too. So a question coming from the audience, something that Bastian had raised. Carrie, please answer from your perspective. And then I throw it open to the rest of the panel. Please answer that, because that's something that a lot of people talk about. Carrie, over to you.
For the last 4 years, I've been working with the Finnish fact-checking organization called Faktabaari. And we are terrified how the big social media platforms are kind of collecting data on us and using it not against us, but they are making money with our data. And let's say it's very much linked to the spread of misinformation, disinformation. And I wouldn't like to get this kind of personalized micro advertisements linked to my condition, because the platforms could sell it to whomsoever, and not only with the good purpose. There is so much kind of health-related rubbish going on in the social media, a lot of false information. And for example, the consolidated fact-checking database on COVID-related misinformation is there are over 9,000 different fact checks on different things. So I'm quite the personal data, and I mean my name, my email, my telephone number, my address is precious. My profile. In Finland, I signed a document that I give permission for research to use my data, which means that they are having not my name, but they have my profile, my age, my height, my whatever information, my laboratory results. And I don't know if that is preventing the research organizations to find out information. They don't need my personal name, my personal email, or my telephone number. So I would be pleased to share my data based on my own consent with the pharmaceutical companies. But I don't want it to be used personally against me or for me. So this is my takeaway. So this is a difficult thing, and I know that we are not going to have a solution here, but first of all, I would like to have a European database where we have European data prescriptions. The comparison with the credit card was not the best possible because there are so many frauds made by credit cards. But I'm a kind of solid database where people can have their information, their prescriptions Europe-wide. So yes.
Thank you, Carrie. So two different points of view, but also similar, converging somehow. Over to the panel. You got a Q&A through from, and I think, Joao, you've also raised very similar issues on your Q&A on the chat. Anyone want to respond to both these lovely folks who are talking about their points of view on what a patient wants to see? By the way, I have a son with type 1 diabetes and he's had it for 27 years. And what he wants from his data is very different from what I as a doctor might have seen. But it's really important that we hold that view. Magda, you unmuted yourself. Please go ahead.
Oh, thank you. I actually agree with both perspectives because I think they are converging. So I agree that oftentimes by completely anonymizing and doing everything in aggregate, that doesn't help neither the research nor the healthcare systems nor the doctor. But I also agree that having information about profile, it's oftentimes enough, and all this personal information, and especially the advertising, is really not necessary. What I can see in the big data projects that we are trying in public-private partnerships, where public and private partners bring together the imperatives of protection on the one hand and of legitimate research purposes on the other hand, is that we need to actually make it easy to contribute the data and incentivize that, be it passive or active, make it easy to make sense of the data so that the return on the data to the patient, to the doctor, to the researcher becomes obvious. And the third one that you both addressed is the access question. So what do we have access to? Are we having access to insights? Can we ask the question and then the research is done and the insights come to whomever needs to know? These are probably the solutions that are already emerging today. So I would say we actually develop those solutions every day. We need to scale them up and implement at a much larger scale than what we have today, and stop being afraid of abuse and misuse, because this is really inhibiting the research. One last point: secondary use of data. Without that, we are not going to do all of what we have done, or all of what we have discussed today. And this is one of the points that has not been resolved as yet, where we are struggling with informed consent forms and reconsenting and re-reconsenting, and an ethical committee still being blocking our ability to research, to the points that Bastien made earlier. So I think this access issue with reuse of data are the first things that we need to absolutely address together collectively, and reapply the solutions that have already been invented, and we are just not scaling them up at a much larger scale than we should.
So Magda, really great insights into this, and thank you for that. Just on another note, which is similar but not similar, possibly related, is empowerment, right? It creates a different relationship between the person who owns the data, which is Stan talked about it, the healthcare professional, the system, and yourselves that are looking for access to records, to personalized medicine, perhaps, and to look at new medicine, new innovative technologies that can help people with diabetes. So I'll come back on the empowerment question. And I have lots of stories to tell on that, but I shan't bore you to tears on that one. From Jose, I was going to come to you, Jose. I wanted to talk to you about, from a healthcare professional perspective, what would create that empowering relationship between you and the patient on data for diabetes particularly, that would make the person's life, and Carrie touched on that. He wants his record to be available everywhere he goes. He wants to be able to get his prescription where he goes. He doesn't want to have to repeat his blood test when he's had it 1 week ago. But from a healthcare professional's perspective, how does that empowerment story sit with you?
Of course, this is an important point of view, because sometimes we register some subjective points, and this is quite our impression. It is not easier to put them in the hands of the people that consult us. And what happens nowadays with all these techniques, that we are more and more objective in the data. In this objectivity, there will be no problem at all for patients can consulting our data and our registers. I remember a doctor in Açores that the only register that he has, give it to the patient, and when the patient came again, he comes with his own register. So the register is every time in the hand of the patient, and never in the hands of the professional. But we need one point that I was considered to put here. We need to have a great empathy and not forget the bureaucratization of this kind of medicine, conducted by numbers and by algorithms and by some word. I think the access to the doctors, to the patient organization, to the woman people is every time very important. I remember one of the most important international companies in technology. They had a great study in England to bring an algorithm about what people with diabetes must do to be carrying themselves. And after 6 months, they give up, because they need someone, woman, between the data and the people. So we need not forget this. And the empowerment only comes by this relationship. We must be there, not to say what they are doing, but to support what are the decisions of people with diabetes. And this is one of the important that we must put here. When with Nikki, when we discussed before, if it is a point of view of the patient and of the population, I consider that we need to have also a special point of view of the doctor, of the healthcare professional, because we need data of this individual to go inside, to make proposals to them. And there, the social determinants are fundamental. Because if I don't need what is personal life, I'm not able to say how can it achieve a better control, including if it is not a good control, but it's the best control that that kind of person can have.
Thank you, Jose, and always the voice of reason, the humanity we mustn't forget, which a computer might not be able to give you, but could empower you. So Stan, you wanted to come back on that.
I think the word empowerment must mean to empower people to do what they want. You don't empower people to do what you want. You empower them to do what they want. So back to the patient-centric, funnily enough. But I think empowerment means ownership of the data. And I think we can link this back to the topic we've just been talking about consent. What could be more empowering than controlling with your consent what the use of the data is? And, you know, we recognize that there's a balance to be struck. But the key to consent for me is to put the patient there for consent. And I think people have a lot of fear, not, you know, they will authorize party A to access their data. But then if party A passes it on to party B and party B passes it on to C, the patient has no, or the person with diabetes has no control over that at all. If they've got a personal care record, that gives you the vehicle for that one-to-one ability to gain consent for each of those steps. Now, it might sound complex that I authorize party A to use my data for this purpose. If party A wants to pass it to party B to use for a different purpose, they have to come back to me. I have to consent for party B to use it. And if party B wants to pass it to party C for a different purpose, again, I need to be able to give my consent. It sounds complicated, but you know, in a blockchain world, you can do that kind of thing. So I think the empowerment is you're empowering people to do what they want, not to do what the system wants or doctors want. And therefore, that's personalization. I can't personalize my doctor's records, but I can personalize my own personal care record. I can make my personal care record adaptable to meet my needs. And Jose said that about my support, supporting me. And everybody's very different. We would all want different modules and different functionality in our personal care record. There is no personal care record that suits everybody and is the same for everybody, nor is there a personal care record that suits me for the whole of my life. What I might want my personal care record to do for me at the age of 20 won't be the same when I'm 30, 40, 50, 60, 70, and so on. It won't be the same if I've got diabetes and hypertension, or if I start to get arthritis as well. So you can't cover all that in a doctor's record as well. And I think empowerment is empowering me to use the data, to control the data, and for it to do what I want to do.
Thank you, Stan. So I'm going to just flip the discussion slightly to include the two folks that we have here who have health systems perspective. Quite correctly, Nick, you talked to me about value-based care. Now, both Tanel and I are trying to work on value-based care in different countries. And I've done this for a living for the last sort of 10 or 13 years now. Correctly agree with you on value-based care. What is the value? So I'm going to flip the question to you, Nick, first to start off with. Is from your perspective, and you've done such a lot of work on patient-related, and I'd like to make this very diabetes specific because we are on a EASD platform where the IDF. From your perspective on value-based care for patients with diabetes, and I'm including everybody with diabetes in this, what is your what would be your ask? Here's your soapbox, Nick. We know about interoperability and all the rest of it. On patient-related outcome measures, what's value for you? What do you think is value? And what do you think is value for patients? And I'd like Tanel to respond to that as well from a systems perspective. And then I'm going to bring in Bastian and Carrie to respond to you guys. Please go ahead, Nick.
I'll try to. Well, first, from a system perspective, I hope that people don't get diabetes. So I will do my best to work on risk factors and to calculate the burden of the diabetes and to convince policymakers that they should have policies in place in all areas that reduces the number of people who get diabetes as much as possible. Again, I'm a professor in social medicine, public health, so that's my first. My second, if you ask me the question, what is the value of diabetes, then I assume people have diabetes. And there I think that apart from managing it from a clinical perspective, HbA1c, complications, check your eyes every year, have a look at the food, not get an amputation. It is far more people understanding, empowering to really manage their own behavior and situation in such a way that they can control the disease. So for me, that's the individual patient-oriented value. But yes, I'm looking from a system perspective. So I speak with countries and I try to look at amputation rates and registries. I look at diabetes at patients. I look at laboratory volumes, basically to see how countries are doing. But for patients' reported outcomes, I would really like to see that information is part and parcel of the dialogue in the consulting room. So I will ask countries, do you use this? Is this infrastructure in place? And interoperability, yes, but it's still a big issue. It's partly the policy issues of having access to the record and having your own data, but also the interoperability of having that data available. There are lots of the electronic health records in the world don't opt for building prompts in there, and I see now a lot of separate patient portals being set up using for it the wrong way. And I see in small countries thousands of initiatives of having different prompts for all the different diseases. So that needs some coordination. If I can be on the soapbox thinking about your countries where you are still developing things, please look whether there's a unique patient identifier and that can be used for linking data. That would be my first. I learned that in the last 15 years. I started with a bunch of OECD countries where it was not possible. Luckily enough, we see now more linkage. The other part is, of course, how you balance privacy by design versus getting consent. I see member states who are not implementing the privacy by design consequences, but are very good through their legal political system to get a whole consent industry where you have to sign up for this and this and this and this. That even have adverse effects. So in some countries, the consent for sharing your vaccination information with the national system is as long a page long as the side effects of the vaccine. So that introduces fear, and the net effect is that people think, "Oh, there must be something fishy. I'm not going to do this." So there is a story. So my ultimate pitch there would be you need to have trust in mainly also the public bodies like the politicians, the political system that is handling this. And that's my reaction to the person from the UK. If you associate it, and that's a political reality, if you associate it with selling data and market and other things, this is a public good that needs to be cared. You can have public-private partnerships to guide it. Again, the OECD already in 2017 has a set of recommendations, which is the highest level thing you can do on how you set up a governance that keeps balancing these issues. That needs to be implemented. But at the end of the day, the trusts in the system of this data are used for the right reasons and are good for me for getting better care, but also contribute to the better of the whole. That is a common responsibility. It starts with politicians having sufficient trust in the systems, but also the providers and the industry to make that pitch. And that's a hard one. We see now with also selling and convincing people to get vaccinated that you run into the same thing. So for me, it's not that much the technique. I can see the different shades of animicity, of aggregation, pseudo-animicity, and then the statistical small cells that end up with the disaggregation. But I'm pushing for linkage capacity, but for getting a good governance model, you really need sufficient trust to see data as a commodity that can be turned into information. And that is essential for bringing healthcare further.
Thank you, Nick, and really interesting threads there. Tanel, a response from you on health systems and value-based care and the use of data, patient-related outcome measure data.
Well, I can obviously subscribe to everything that Nick said, quite frankly. So I'm just thinking, you asked if I would be in my soapbox, so to say. Well, first I would like to be absolutely sure that I would have a proper information and IT infrastructure in place. Right, it has been talked already several times today, but really that you have a easy access to information, to data. Right, this is the first place, and this is of course very much to do with national standardization and also taking care of privacy concerns nationally. Now, the second point, I think, what Nick started is that I would be interested that I wouldn't have a diabetes at all, right? Probably in the first place. Really, I would like to ensure that my patients and probably my primary care would be much interested in putting the best use of the data and applications for preventive purposes, right? So that requires probably some more forceful public relations campaign, as it has been at least Estonia until now. Recently, until now, I would be also interested that my primary care or my social care, whoever coordinates this from the population point of view, would be interested in ensuring that the level of diabetes is low, which in turn depends very much on the preventive activities, on promoting the lifestyle choices. And of course, obviously, when it comes to the treatment of the disease as such, then I really do not have much to add what Nick just said. Now, the third component of that would, of course, be then how to incentivize my change agents or my primary care, or how to incentivize the physicians. Then we come to the questions about the strategic purchasing, right? So how much is this incentives down to the communication? How much is this incentives down to publish to making the information about the diabetes public, for instance, and then to what extent this incentives is down simply to the question how to pay for the prevention and for the care activities. So I think it's the question is is the combination of these three pillars. First of all, as we have talked so much, data infrastructure as such, interoperability, availability. Second point is how to incentivize the prevention, how to incentivize the patients or the people and the primary care level to be interested in prevention, and how to make them be interested to use these applications and data to that end. And the third question is, of course, what you can do on the system level to provide perhaps some monetary incentives or some transparency incentives for instance, for primary care to be really interested that the population is as less diabetes as possible, and B, once it is there, then how to get the best results. So which is probably mostly comes also to the new payment models. Thank you.
Thank you, Tanel. And we've only got half a minute left. In this fascinating discussion, we've lost track of time. We have 277 people online viewing us live and listening to us. So we had a great audience as well. I didn't get so many questions from the audience. But final, just like 10 seconds from Bastian and Carrie. Would you like to have the final word? And I'll just like to sum up. I might take 2 minutes extra. Go ahead, Bastian.
One thing we maybe didn't really discuss about, but we did talk about data leading to empowerment and trust in the system, etc. One thing that data in a personalized health record on my cell phone, as Stan was referring to, leads to is it actually enables me to have more quality time with my endocrinologist or with my GP, and I think that is great as well.
Great. Carrie, one final 10 seconds from you.
I perfectly agree that there has to be a trust for the system to provide data. In Finland, I think we have a good example of the system which has been created and works. And I do agree as an educator that the prevention and the information in the first place is absolutely vital that we don't forget it. Thanks.
Thank you very much, Karen. Thank you all for being so brief and so succinct with your answers. As your chair, I'd like to thank you all for a fascinating, interesting discussion. We hope we'll follow you up with this. We still haven't got into the nuts and bolts of what a patient wants from their data-driven insights, how they'd like to interact. We've had some start to that and lovely responses from all of you. Thank you very much for your time, and thanks to EASD for letting us host this. Have a lovely afternoon, everybody, and we'll see you again.